think many of the problems that we see in anophthalmic sockets are due to orbital implants. So why do we use orbital implants? Well, first and foremost, we need to provide volume because if we can give a nice, relatively large orbital implant, that means that we can have a smaller prosthesis. Smaller prosthesis is going to move much better than a thicker prosthesis. So that will enhance the motility. And then also, we want to maintain the anatomy of the orbit. We've really yet to find the ideal implant. That's why we have so many implants out there. What would be the definition of the ideal implant? Well tolerated, provides good motility, low complication rate, gives good volume, simple to implant, and also affordable. With regards to anophthalmic sockets issues, we'll see volume issues, we'll see infection, contraction, pain, migration, exposure, as well as extrusion of the implant. So let's talk about some of these things. With regards to socket contraction, I think what you'll notice on these patients is that they'll come in and they'll tell you that they're having a hard time retaining their prosthesis, often due to the loss of the fornices. You can also get entropion, and basically you really need to look at the fornix closely to see why you're having a problem. If this is progressive, we had speakers before noted that you could use 5-FU, and there is success in using this, especially if you have active inflammation. But often the treatment is going to be surgical, especially if the insult has already occurred. So what are we going to do? It's going to depend upon the grade of the contraction. We're going to expand the surface of the socket, reinforce the fornices, and treat any underlying inflammation. Preferably, you're going to treat that inflammation before you do surgery. You don't want to do surgery on an actively inflamed socket. So if you have active inflammation, using 5-FU injections, I think, would be very reasonable. With regards to minimal contraction, this usually results in entropion. Maybe you'll just see lash ptosis. So the patient will come in and you'll notice that their lashes are down a little bit. You could try a tarsal fracture, but sometimes we have to go to a mucous membrane graft or hard palate. I like hard palate, especially if it's for the lower lid. Gives me a nice firm graft, and I think that that's my go-to in these patients that have a poor inferior fornix. With regards to severe contraction, these can be very challenging to take care of, and this is often seen after patients that have undergone radiation. And for very extensive conjunctival shortening, you could consider a dermis fat graft, but remember, you need to put that dermis fat graft on a relatively healthy socket. So if you don't have a good bed, that dermis fat graft will not survive. So I'm just going to give you an example where we sort of did heroic measures in order to try to expand the socket of this 10-year-old female. She had a history of retinoblastoma, history of bilateral enucleation, also had radiation therapy, status multiple attempts to try to reconstruct the socket. So here she is, pretty severely contracted bilateral sockets there. The issue more than anything else is that because of her radiation, she has a poorly vascularized socket on each side. So somewhere or another, we need to mobilize vascularized tissue into that socket so that our grafts can survive. So we did bilateral temporal parietal fascial flaps. You could do temporalis muscle flaps as well. She had already had multiple mucous membrane grafts, so we took mucosa from her inferior turbinates, placed fornix sutures, placed rigid conformers, and I put her on bilateral tarsorrhaphies for 4 months. And we were able to make a socket, but this put her through a lot. This was not just a little procedure. This is something that she had to really be motivated in order to go through, and you can see that she can retain prostheses now. With regards to displacement, this could be migration, exposure, or extrusion of the implant. I think first and foremost, we want to prevent these things. So, it can depend upon the implant used, where the implant is placed, whether you wrap or don't wrap the implant, surgical closure, and then also take into consideration the patient's health. If this is someone who has very poor conjunctival tissue due to previous surgeries or autoimmune disease, this would be something that maybe you'd want to go to a primary dermis fat graft. Migration usually refers to slippage of the implant outside the muscle cone, but also you can get tilt, especially if you use a quasi-integrated or integrated implant. What are the causes? Again, implant, wrapping, surgical enclosure. I think it's relatively uncommon for a porous implant to migrate in the socket. It's usually going to be with a non-porous implant. So wrapping non-porous implants probably will prevent some of the migration. With regards to surgical technique, I don't imbricate muscles over the implant, although I understand the advantage of trying to get vascularized tissue in front of the implant to prevent exposure, but in general, sometimes those muscles are tight and the implant can slip through the muscle cone, out of the muscle cone. What are the symptoms of these problems? Often this is detected by the ocularist, progressively having to change the fit of the prosthesis or a decrease in motility of the prosthesis. If this is something new, especially in a patient with a previous malignancy, I often will consider a scan just to make sure that something isn't pushing the implant out of position. But conservatively, you can refit the prosthesis, or if they need to go to surgery, you can remove the implant, place a new implant into the muscle cone. Sometimes actually have to place a dermis fat graft because you'll have these problems where you'll put another implant in and it will continue to migrate. So exposure of the implant, some people believe that this is a type of migration, an anterior migration. And basically what this means is that you have visible implant on examination. So you have an exposed foreign body. This is not going to be tolerated by the body, and this is going to worsen. What are the causes of this? Sometimes inadequate surgical technique, poor tissue, as we had mentioned earlier, if this is someone who has a history of autoimmune disease. The implant type can sometimes do it, and sometimes if it's a poorly fitting prosthesis, that could do it. What do we do to try to prevent this? Well, we place that implant relatively posterior. We want to make sure that we remove any previous hardware, especially if it's an evisceration. We want to make sure that sclerobuckla is out, any glaucoma drainage implants are out. We don't want to leave those in the socket if we're removing the eye. I don't place non-absorbable sutures. I think that those cause problems. And I do place implants posterior to the posterior sclera for an evisceration. And I always remind my trainees that the closure is almost the most important part of the operation, in the sense that that's when you have your chance to prevent complications. So this is just the closure of an enucleation. And this is a double closure. I close tenons separately, and this is done with interrupted, buried 5-0 vicryl sutures. And again, you want to make sure that you don't, that you have a good tenons closure here. You haven't buried any epithelium at all. And then I'm going to run a 7-0 vicryl suture to close the conjunctiva. And I think that you do a meticulous closure that'll decrease your chance of exposure. With regards to evisceration, I've opened the posterior sclera, and I'm going to place a non-porous implant into the muscle cone, posterior to posterior sclera, and then I close the posterior sclera, and then on top of that, I'll close the anterior sclera, followed by the conjunctiva. So that gives me 3 layers in front of this implant. And I think that this really helps decrease your chance of exposure later. What are the symptoms of exposure? New discharge, bloody discharge, pain. Obviously, you're going to see it on examination. You'll see a visible implant, but if you ever see a pyogenic granuloma in an anophthalmic socket, you have to consider that this is probably an exposure somewhere. So if you see that pyogenic granuloma in an anophthalmic socket, think exposure. For small exposures, consider primary repair. For small to medium exposures, scleral patch graft is what I usually do. And this is just an example of a scleral patch graft. I'm going to widely undermine along the surface of the implant and make sure that this can close without tension. And then I'm going to place a piece of sclera under that and then close both the tenons and the conjunctiva over that. This is basically what the sclera looks like afterwards. For medium to large exposures, you probably exchange the implant, or you can place the implant posterior to posterior tenons on the new one. But again, you may lose some conjunctival surface, which will result in shallowing of the fornices. So, for these large exposures, the nice thing to do is to do a dermis fat graft so that you can expand the conjunctival surface, as well as place a living implant that won't cause any problems with regards to exposure. However, the volume in dermis fat grafts can be relatively unpredictable. I'm going to skip that. So basically, the goal in each of these situations is prevention, detect it early, make sure that these patients are getting their exams, and discuss the symptoms with the patients. Thanks.